Hey there, everybody. How's everybody doing on this beautiful day? Welcome to my session of Lipids 101 Cholesterol Metabolism for MLS ASCP Prep. My name is Thalia, and today we're diving into the world of lipids, essential for energy, our membranes, and more. We'll cover the biochemistry, pathways, normal and abnormal states, properties, key components, testing, and clinical correlations. This is all high yield for your ASCP exam, so pay attention to lipoproteins, apolipoproteins, and disease links. Let's get started. First, let's break down what lipids are at their core. What are lipids? Lipids are fatty, waxy compounds that don't mix with water but are crucial for life. The biochemical and theory and physiology are these as follows. The lipids provide energy storage. They build cell membranes and act as precursors for hormones like estrogen and testosterone. Their key roles is to build the cell walls, absorb fat-soluble vitamins such as A, D, E, and K, and insulate the body. It also makes steroids. Cholesterol is a key lipid that maintains membrane fluidity and is the building block for bile acids and vitamin D. It is also transported by a lipoprotein. And since the lipids are hydrophobic, they're transported in our blood by lipoproteins. These are complexes with apolipoproteins, which are carrier proteins that stabilize and direct them. So apolipoproteins are like GPS for lipids. Without them, transport fails, leading to dyslipidemias. This is an often topic questioned on the exam, so write that down. Now, how do lipids get into our system? Let's start with the exogenous pathway. Exogenous pathway from food to body. So let's track that meal that you just ate, whatever it is. From the meal that you just ate, you got a bunch of cholesterol and triglycerides. For example, some foods like burgers or eggs. After that is the breakdown of it, of whatever it is that you ate. The pancreatic lipase and bile acids in the intestine break them into free fatty acids and cholesterol. And this happens by a key step with the Niemann-Pick C1 like 1 membrane protein. This protein is like a gate on the intestine cells, if you will. It lets the cholesterol in. And as a TMI binds to the active site of the Niemann-Pick C1 like 1 membrane protein, NPC1L1 for abbreviation. And when it binds to the active site, it basically locks that gate and it cuts cholesterol absorption by half. And it hugely helps lowering LDL. And I'd like to point a distinction between Niemann-Pick disease. The abbreviations are similar. So it's important to know the difference that there is a Niemann-Pick C1 like 1 membrane protein, but he works in the gut, whereas there is a Niemann-Pick type C disease, for example, that is a lipid disorder, as well as a Gaucher disease, which we'll talk about that later. But there's a distinction between those two abbreviations. They look the same, so be cautious on some of the abbreviations that are around, okay? Because they might look the same, but they do not mean the same or have the same action or mechanism. Next is that the intestine cells pack lipids into chylomicrons with apolipoprotein B-48. This is an apolipoprotein. Apolipoproteins are carriers. They carry our lipids, our triglycerides, our LDLs, our HDLs, and our lipids through our body. And because some lipids can't go through our body because they're hydrophobic, and we'll talk about all that later. But so apolipoproteins carry these lipids in our body. So chylomicrons are carried by apolipoprotein B-48. Whereas LDL, for example, is carried by apolipoprotein B-100. Next is that the chylomicrons carried by this apolipoprotein B48 deliver triglycerides to our muscles and fat by this lipoprotein lipase. This is turned on by apolipoprotein C2. I know that's a lot, and I'm gonna explain that more later when I break down what these apolipoproteins are and lipoproteins are, because it's a lot of words and I get it. And then it's the leftovers is the clearing part. So the leftovers, so cholesterol-rich remnants, right? They're cleared by our liver with apolipoprotein E, and I would just like to note that the the ezetimibe targets the Niemann-Pick C1 like one in the gut, not Niemann-Pick disease. So it's important to know those two distinctions. It's also important to know what apolipoproteins carry what lipids and what drugs might block the Niemann-Pick C1 like one's active site. For example, simvastatin. Statins are drugs that would help reduce the cholesterol production in the liver by inhibiting the HMG-CoA reductase, the rate limiting enzyme in the cholesterol synthesis. So that is an example of a medication that would inhibit the cholesterol from overproducing in the body. The endogenous pathway. This pathway, the liver makes the lipids here. This is a cholesterol factory. So the liver makes cholesterol using HMG-CoA reductase, like a factory switch, if you will. The simvastatin, as I mentioned in the previous slide, binds to its active site, and it jams the machine to cut cholesterol production, lowering LDL. Fatty acids can turn into ketones, acetoacetate, beta-hydroxybutyrate, or acetone, for energy in diabetes or fasting. The liver then packs cholesterol and triglycerides into VLDL with apolipoprotein B100. VLDL delivers triglycerides via LPL, turning IDL, then LDL. Next, LDL, carried by apolipoprotein B100, drops cholesterol to cells via receptors. Too much LDL clogs arteries, aka atherosclerosis. This is bad, quote unquote, bad cholesterol. HDL with apolipoprotein A1 cleans up extra cholesterol and it sends it back to the liver. Just a tip, simvastatin targets HMG CoA reductase to lower LDL, apolipoprotein B100. That apolipoprotein is the one that carries LDL. So remember that they two go together. And so this signals, the ketone signal DKA. So do you remember which drug might block the cholesterol factory? If you guessed simvastatin, you were right. Simvastatin, statins, atorvastatin as well. Normal lipid levels. So, starting with total cholesterol, we want to see values under 200 milligrams per deciliter to keep the arteries clear. This is a healthy heart. And for LDL, it's considered the bad, quote unquote, cholesterol. This we would want to see under 100 milligrams per deciliter. This minimizes the cholesterol buildup because LDL is the one that delivers the cholesterol. And do you remember what apolipoprotein carries LDL? Well, if you forgot, that's okay. That's apolipoprotein B100. For HDL, our good cholesterol, quote unquote, good, we want to see that above 60 milligrams per deciliter. The HDL is good because it removes excess cholesterol. And for triglycerides, under 150 milligrams per deciliter, this supports the energy without the excess. So this is where we want to see that. We want to see it under 150 milligrams per deciliter. And so this is important to us in the laboratory because some of these tests are done with fasting levels between 9 to 12 hours, just water, to avoid any interferences from food, like chylomicrons from let's say a taco that you ate. And so ASCP loves these numbers, and so they can show up in any case study in school. And so it's important to know these values. Abnormal lipid levels and diseases. When lipids get out of whack, we're talking serious health issues, from heart attacks to rare storage diseases. Let's break it down. High LDL means too much bad cholesterol, forming artery plaques, atherosclerosis that can cause heart attacks or strokes. High triglycerides, over 1,000 milligrams per deciliter, overload the pancreas, triggering acute pancreatitis. That's an emergency. Think severe belly pain. Low HDL, below 40 for men or 50 for women, ups heart disease risk because it's not cleaning up cholesterol well. Genetic dyslipidemias like familial hypercholesterolemia cause crazy high LDL due to broken LDL receptors, leading to xanthomas, fatty lumps on the skin. Then we have lipid storage diseases and ketones. Gaucher disease is a disease that is missing an enzyme, glucocerebrosidase. And so a fatty molecule, glucocerebroside, piles up, making the liver and the spleen huge, aka hepatosplenomegaly. Then we have Niemann-Pick disease, type AB. This has a buildup of sphingomyelin from a faulty enzyme. And Niemann-Pick disease also has a type C, which is trickier because cholesterol gets stuck in cells in the recycling bins called lysosomes because proteins NPC1 or NPC2 are not working. This causes brain damage and organ issues. Then we have ketones. When triglycerides break down a lot, like in diabetes or fasting, the liver turns fatty acids into ketones, like acetoacetate, for example, or acetate and beta hydroxybutyrate for backup fuel. So too many ketones in diabetes cause diabetic ketoacidosis or DKA, aka making blood acidic and dangerous. And these are all important to know for our ASCP focus. So know the lipid storage disorders, ketones, all three of them, acetoacetate, beta hydroxybutyrate, and acetone. And and with beta hydroxybutyrate for our notes is that it's the most abundant in acetone linked to DKA because of the fruity breath, making it like a memorable type of thing, right? So make sure that you study up on these. Lipid properties, how they work. Let's dive into what makes lipids tick. Their physical and chemical properties. These are the building blocks for energy, membranes, and more. Here's a breakdown for ASCP prep. Triglycerides. These are the body's energy savings account, made of glycerol plus 3 fatty acids like butter for solid fats or olive oil liquid. They pack a whopping 9 calories per gram, twice as much as carbs or proteins. They're stored in adipose tissue or our fat cells. They're broken down when we need fuel, like in times of fasting or exercise, or in diseases such as diabetes. Enzymes like lipoprotein lipase, LPL, splits them into fatty acids and glycerol for energy. In diabetes or starvation, the liver turns those fatty acids into ketones, acetoacetate, beta hydroxybutyrate, and acetone for backup fuel. There are too many ketones that can cause DKA. And high triglycerides over 1,000 milligrams per deciliter can also cause pancreatitis. Phospholipids. These are membrane superstars because they're amphithetic, water-loving heads and have water-hating tails. Picture like a sandwich. The heads face water, and the tails hide inside. And it forms the cell's membrane bilayer. The key player in this is lecithin, which is phosphatidylcholine. It's got a glycerol backbone, 2 fatty acid tails, and a phosphate head with choline, making membranes stable and fluid, like in our brain or liver. And you'll find that lecithin in egg yolks and also soybeans, And the ASCP might link it to Niemann-Pick, where another phospholipid, sphingomyelin, piles up due to enzyme defects, which we know that Niemann-Pick is a lipid storage disorder. Cholesterol, this is a steroid molecule that slips into membranes to keep them flexible. Plus, it's used for hormones and bile acids. Lipoproteins, these are like our delivery trucks. The lipid cords of triglycerides and cholesterol wrapped in protein shells, for example, apolipoprotein B100 for LDL, to travel in the blood. The ketones, acetoacetate, beta-hydroxybutyrate, and acetone, are water-soluble molecules from triglyceride breakdown in the liver during fasting or diabetes. They're backup fuel but cause DKA if excessive. Just a tip for my students, triglycerides store energy and feed ketones, testable for DKA and pancreatitis. Phospholipids, like lecithin, form membranes. Quick question, what do triglycerides do? Right, they store energy. They store about 9 calories per gram. So focus on the mechanism and how these lipids work in our body. Key lipids and proteins. So we have lipoproteins, chylomicrons that come from our diet, our VLDL, IDL, and LDL that come from our liver, and HDL recycles in the excess cholesterol. Then we have phospholipids such as lecithin and sphingomyelin. These help us with our membranes, mentioned in the previous slide. Our cholesterol, these help us with our membrane flexibility and hormones. Then we have our apolipoproteins such as apolipoprotein B48 that carry our chylomicrons. Then we have apolipoprotein B100 that carry our LDL, VLDL, IDL. And then we have apolipoprotein C1 that carries HDL, and apolipoprotein C2 carries LPL, and apolipoprotein E helps with clearance. And I'm going to provide a worksheet where you can see where I put them together. That way you can see it versus and also hear it. Testing lipids, how us MLS detectives figure it out. So we in the laboratory run lipid tests to spot heart disease or DKA risk. And what we measure in a lipid panel, we check for total cholesterol, the HDL, which is the good cholesterol, LDL, the bad cholesterol, which is carried by which apolipoprotein? ApoB100, right. And triglycerides, which store our energy. Sometimes we measure non-HDL cholesterol or apolipoprotein B100 to count LDL particles for cardiovascular disease risk. For diabetes, we test ketones. Serum beta-hydroxybutyrate is best, or urine dipsticks for acetoacetate to catch DKA. That acidic blood is an emergency, so we definitely need to be on top of that. The methods that we use are enzymatic assays. Think of cholesterol oxidase for cholesterol or glycerol kinase for triglycerides. These create color changes we measure with a spectrophotometer at 510 and 570 nanometers, like a rainbow telling us lipid levels. For apolipoproteins like ApoB100 or ApoA1, we use immunoassays with antibodies in specialized labs. Ketone test, serum beta hydroxybutyrate is super accurate for DKA, while urine dipsticks catch acetoacetate. Precautions: patients must fast 9 to 12 hours, water only, to clear dietary chylomicrons. Remember, chylomicrons come from diet. Apolipoprotein B48 carry chylomicrons. Our triglycerides and LDL results can get messed up if the patient does not fast in the time frame that they're supposed to. And we have to test in a steady state, which means no recent illness like infections as inflammation can mess with our lipids. We have to collect blood in serum or EDTA tubes, and we can't leave the tourniquet on for too long because it can cause hemolysis, ruining our results. So it's important for our phlebotomists and our nurses to know to not leave the tourniquet on for long. Once you palpate and find your vein, poke your vein. You got your tourniquet on, but as soon as you start to see blood come out, you need to take off your tourniquet, because that is how they taught us in school. And I've seen in the hospital where there are drawers where they'll leave the tourniquet on for like 40 seconds. And it's like, what are you doing? And you don't want to always say something because you want the person to learn, but it's also important for them to understand, like, when you see blood coming out already and you got a good, it's time to take off the tourniquet, because it can, number one, hurt the patient, and two, cause our results to become hemolyzed. There are also interfering substances, such as if you ate a big burger. This can spike our triglycerides, our chylomicrons. Medications, such as ezetimibe, can block our Niemann-Pick C1 like 1 membrane protein in the gut. Or drugs like simvastatin jams our HMG-CoA reductase in our liver. So it lowers cholesterol, while beta blockers, steroids, or retinoids can raise lipids. So watch for hemolysis, which is the red cell breakdown, or lipemia. And lipemia is a cloudy plasma from high triglycerides. They can both mess up our assays. And you would see it on top of the specimen. You can see chylomicrons. You can see the lipemia. And for troubleshooting, if triglycerides are over 400 milligrams per deciliter, the Friedwald formula for LDL and total cholesterol minus HDL minus triglycerides divided by 5 fails. I know that was a lot just now. I'm going to write down that formula. But so we use this formula to calculate LDL and total cholesterol, right? So we use it as a direct LDL assay or ultracentrifugation. And for any type of lipemic samples, if you run into any of them, what you would do is you would dilute them or use a clearing agent and check for turbidity. Ketone dipsticks can also give us false positives with drugs like captopril. So when we confirm this with serum beta hydroxybutyrate. So just a tip, we know that fasting clears chylomicrons, which are carried by which apolipoprotein? ApoB48. Ezetimibe and simvastatin affect results, and ketone tests catch DKA. So just a quick question, why do we have to fast for a lipid panel again? Right, that's to clear our chylomicrons. And what's the best ketone test? It's serum beta hydroxybutyrate. Understanding the lipid test results. So after we do our test and we've looked at our specimen and everything is good with that end, it's time to interpret these results. And this is where it starts to get more fun in the laboratory, because now we're about to diagnose our patient. And even though we don't have any patient contact, many of us in the laboratory prefer it that way, we enjoy the science part of it, the figuring out the answer. So this is where we do that. We get to figure out the answer. So, and we do this with the help of our laboratory test values. and we correlate them with any clinical significance. So for total cholesterol, the values where we would what would help us decipher case studies or real diagnosis in a laboratory. We want to aim for less than 200 milligrams per deciliter is good. It means that's low heart disease risk. 200 and 239 is borderline. And anything greater or equal to 240 means a high risk. And that could signal an atherosclerosis risk, especially from LDL with apolipoprotein B100. LDL, low density lipoprotein, this is our bad cholesterol. He's carried by apolipoprotein B100. Less than 100 milligrams per deciliter is ideal, especially for high-risk folks. 100 to 129 is borderline. 130 to 159 is moderate risk. And greater than 160 milligrams per deciliter screams atherosclerosis. It means that the patient is at risk for a heart attack or stroke. Doctors might want to prescribe drugs, for example, as I mentioned, ezetimibe, that blocks that Niemann-Pick C1 like 1 membrane protein in the gut, or simvastatin that jams HMG-CoA reductase in the liver, both lowering LDL, the bad cholesterol. The HDL, or high-density lipoprotein, are good cholesterol. The apolipoprotein A1 clears the excess cholesterol by reverse cholesterol transport. So we want to see HDL at 60 milligrams per deciliter. This means that our heart is protected. In men, if it falls below 40, in women, if it falls below 50, it raises the cardiovascular disease risk because that means that it's not cleaning up LDL well. So HDL is the one that clears up any excess LDL. So we want HDL to be working well. Triglycerides, these are the ones that store our energy and are chylomicrons, and they're carried by apolipoprotein B48. And our VLDL is carried by ApoB100. And for the ranges of this, less than 150 milligrams per deciliter is normal. 150 to 199 is borderline. 200 to 499 increases cardiovascular disease risk. And anything greater or equal to 500 is very high. And anything greater than 1,000 risk acute pancreatitis. So our pancreas gets inflamed by too many triglycerides. And when there are too many triglycerides, not only can it cause an acute pancreatitis, it can also cause triglyceride breakdown that feeds ketones, and it can make a diabetic patient prone to DKA. In non-HDL cholesterol, we calculate it as total cholesterol, HDL minus LDL, VLDL, IDL with the apolipoprotein B. I know that's a lot. I'm going to write that formula down, the Friedewald. The values for that, we'd want to see that less than 130 milligrams per deciliter is optimal. Greater or equal to 160 means atherosclerosis risk. And this is a better predictor for CVD than LDL alone, especially if triglycerides are greater than 400 milligrams per deciliter. So we use our Friedewald formula up to a point. If it's greater than 400, the Friedewald is not going to work anymore. And so we use all these clinical values to correlate them to diseases and disorders. In lipids, we use these to point us to the direction of atherosclerosis because there's too much triglycerides, because there's too much plaque buildup. We also look for the ketones in the body. What does that mean? Ketones such as acetoacetate, beta-hydroxybutyrate, acetone. What does it mean if there's too much triglyceride breakdown and it causes the ketones? Well, that would point us to DKA. Then we would test that with the serum beta hydroxybutyrate or the urine dipstick. We would also use these values to also point us into lipidoses, lipid storage disorders such as Niemann-Pick, which is caused by sphingomyelin buildup, not that Niemann-Pick C1 like 1 membrane protein in the gut. Remember that these two are distinct. The abbreviation looks the same, but they're not the same. And they're both, yes, blocked by statins, but they're both two different things. One is in the gut, and one can cause a lipid storage disorder. So, as a tip for my students, memorize the ranges and the links to the diseases and disorders that they may be affiliated with, because that is how, in the laboratory, we are able to figure out our clues to come up with our answer. We decipher all of these and we figure out the puzzle. Okay, well, this works, this ties in, that looks good. Okay, well, unfortunately, even though I have all of these results, that means that the patient, unfortunately, is going through some type of lipid disorder issue, or best case scenario, our patient is well and healthy and there is nothing wrong, and it is our job to decipher those results. What are ketones and why are they important? They're small water-soluble molecules: acetoacetate, beta-hydroxybutyrate, and acetone. They're made in the liver when glucose is low, like in fasting, starvation, or uncontrolled diabetes. Think of them as our emergency fuel. How they're made, this is called ketogenesis. When insulin is low, like in type 1 diabetes, triglycerides, those energy storage lipids from our previous slide, break down in fat cells by hormone-sensitive lipase, releasing fatty acids. The liver takes these fatty acids, chops them up in beta oxidation, and turns them into ketones in mitochondria. But too many fatty acids from triglycerides flood the liver, cranking out ketones like crazy, especially in diabetes. The reason why they're important is because ketones are backup energy, giving 4 to 6 calories per gram for our brain and heart when glucose is gone. But in uncontrolled diabetes, excess ketones, especially beta-hydroxybutyrate, lowers blood pH, causing diabetic ketoacidosis, DKA. It's a very life-threatening emergency. It can cause nausea, rapid breathing, and give the patient a fruity breath from the acetone. For testing ketones, we use a serum beta-hydroxybutyrate. It's the most abundant ketone. It's about 70 to 80%, and enzymatic assays measure it accurately. Levels over 3 millimoles per liter screen DKA. Urine dipsticks catch acetoacetate quick, but are less reliable, with false positives from drugs like Captopro. So we check the blood glucose too. Anything greater than 250 milligrams per deciliter with ketones would confirm a DKA. Tip for my students: know the ketones, where they come from. Triglycerides cause DKA, are best tested with beta hydroxybutyrate. So just to recap, what's the most accurate ketone test? Serum beta hydroxybutyrate. And why do ketones spike in diabetes? Because there's low insulin, there's more triglyceride breakdown. So for my students, ASCP exam prep. These are the key lipid points I want you guys to remember. Okay? So for our lipids overview, know your lipids. Triglycerides store energy, 9 calories per gram, like a savings account. Phospholipids, like lecithin, are amphipathic, forming cell membranes with their water-loving heads and water-hating tails. Cholesterol builds membranes and hormones, while ketones, acetoacetate, beta-hydroxybutyrate, acetone are backup fuel in diabetes or fasting. And the ASCP wants you to nail their functions. Lipoproteins and apolipoproteins, chylomicrons, carry dietary lipids with apolipoproteins B48. VLDL, IDL, LDL carry liver lipids with ApoB100, and HDL cleans up cholesterol with ApoA1. Apolipoproteins, ApoB100 is LDL's driver, linked to heart disease. ApoB48 is for chylomicrons. ApoC2 activates lipoprotein lipase, LPL. ApoE clears remnants. And ASCP loves ApoB100 versus ApoB48. Memorize them. Pathways and drugs. The exogenous pathway. This absorbs our dietary lipids by the Niemann-Pick C1-like-1 membrane protein. It's blocked by the azacitidine to cut cholesterol. The endogenous pathway makes cholesterol in our liver by the HMG-CoA reductase. It's jammed by simvastatin to lower LDL, which is carried by ApoB100. ASCP likes to test drugs with pathways, and they like to know if you know, how deep do you know? You really got to get deep into it. For diseases, you got to be able to correlate them with testing and interpretation. So for diseases, high LDL with ApoB100 causes atherosclerosis, which are plaques clogging arteries. Triglycerides over 1,000 milligrams per deciliter trigger pancreatitis. Ketones from triglyceride breakdown cause DKA and diabetes, providing that fruity breath from acetone. Lipidoses, like Gaucher from glucocerebrosidase, or Niemann-Pick sphingomyelin. This is where the abbreviation sounds the same as the other, but it's Niemann-Pick C1-NPC2, which is Niemann-Pick C type 1 and 2 disease. It's a mess up of lipid storage. So don't confuse the endogenous pathway in the gut and then the lipid storage disorder with the Niemann-Pick. And then for testing and interpretation, we run our lipid panels and remember the reference ranges and what the reference ranges mean, and that it's important for the patient to fast between 9 to 12 hours to clear chylomicrons, which are carried by ApoB48. For ketones, we use serum beta hydroxybutyrate for DKA. It's the best. For urine dipsticks, we catch acetoacetate but can trick you with false positives. So watch for interferences such as drugs, ezetimibe, simvastatin that lower lipids. Hemolysis or lipemia can also mess up our results. And the ASCP likes to test for the ranges and the freed wall limits when triglycerides top 400 milligrams per deciliter. So as long as you can just remember the mechanism of how it all works and how it all ties together, and remembering that there are carrier proteins that carry our fat in our blood. Our fat can't travel alone. They need a vehicle to drive, and those are our apolipoproteins. And of course, I've already mentioned understanding, interpreting the test results and the diseases that are correlated with those test results. All right, so we're going to test your knowledge. An example question. A patient has triglycerides greater than 1,000 milligrams per deciliter. What is the most likely clinical concern? It's going down the list before we answer the question. We're starting with A, atherosclerosis. Let's think about it. Can it be this? No, because atherosclerosis is from LDL and apolipoprotein B100. Hypothyroidism can't be because it raises triglycerides, but it isn't the result. And stroke is a long-term cardiovascular disease risk. So it can't be A, it can't be C, and it can't be D, and that leaves us with acute pancreatitis. What is the primary role of apolipoprotein B48 in lipid metabolism? A. Does it activate LPL? No, because ApoC2 activates LPL. Is it the structural protein for chylomicrons? Yes, that is the correct answer. However, we have to keep going. C mediates HDL cholesterol uptake. Well, no, because ApoA1 is for HDL. And does it bind LDL receptors? No. ApoB100 binds LDL receptors. So we have to understand each option being provided to us in order to figure out the best, most accurate answer. Because even though some of these may sound right, it may look right, it might not be the best answer that the ASCP wants. And the way that you're going to get to that answer is if you do process of elimination and you know the deep roots of the options provided. What does ezetimibe target to reduce cholesterol absorption? A. HMG-CoA reductase. B. NPC1L1. ApoB100. NPC1-NPC2. So going in order here, ezetimibe does not target HMG-CoA reductase because HMG-CoA reductase is blocked by simvastatin. And ApoB100 is the apolipoprotein carrier for LDL. It's not a drug target. And NPC1 and NPC2 are defective in Niemann-Pick, unrelated to ezetimibe, which leaves us with B. Ezetimibe binds the active site of NPC1L1, Niemann-Pick C1-like 1 membrane protein. It's a cholesterol transporter in the intestine and blocks dietary cholesterol absorption and reduces LDL with its friendly carrier protein like apolipoprotein B100. A patient's lipid panel shows LDL greater of 160 milligrams per deciliter and HDL less than 40 milligrams per deciliter. What is the primary concern? Well, starting with acute pancreatitis, we look at the results given to us, and we look at the LDL and HDL, and that's not triglycerides. A value of greater than 1,000 milligrams per deciliter for triglycerides would be a red flag for acute pancreatitis. That's not what we're seeing here. For diabetic ketoacidosis, we would be looking at also triglycerides and ketones, because triglycerides in times of fasting or in diabetes, it breaks down triglycerides, except in ketoacidosis, it really breaks it down in massive amounts. It can be incredibly dangerous to the patient. And then, but that's not what we're looking at here. And then for D, Niemann-Pick disease, well, what we've learned is that that's a lipid storage disorder, and it's a bit different from LDL and HDL, as it's defective because of a different protein deficiency or defectiveness. And so it can't be that, because that has nothing to do with that. So it brings us to C, atherosclerosis, which makes more sense because our LDL is incredibly high, our bad cholesterol, it's out of reference ranges, and our HDL is not where it needs to be as well. We want our HDL to be at least 60 milligrams per deciliter. In this case, it's less than 40. So whether it's a male or female, we know that the patient is at risk for atherosclerosis because this is telling us that the HDL is not being able to clear up the excess cholesterol in the body. Ketones in diabetes causes what condition? Well, we have to think about this critically. So in uncontrolled diabetes, we think about what we know about it. Okay, it triggers the triglyceride breakdown and it turns into fatty acids, the liver converts it to ketones. And so when we're thinking about ketones, well, a little bit of ketones is, it could come from fasting, maybe the patient's fasting. But in diabetes, excess ketones lowers the blood pH, which is less than 7.3, and causes diabetic ketoacidosis. So it's important for us to know what ketones are in the body. So we know the answer is B. Okay, this one is easy, but to make it clear is that we have to go down this list. So for atherosclerosis, well, it can't be that because the results from high LDL and with ApoB 100, it's not a factor here because the ketones are too high, so it can't be atherosclerosis. So we rule that one out. And so why can't it be C, Niemann-Pick disease? Well, because that disease is a lipid storage disorder, and ketones are not part of that disorder because it's a disorder because of defective NPC1, NPC2, and it can also be because of the sphingomyelase. So there's a type A and B because of sphingomyelin buildup. So one is because of a cholesterol buildup, the defective NPC1, NPC2, type C, and the other one is a sphingomyelin buildup because of that defective sphingomyelinase. So it's not lecithin, and it's unrelated to ketone production. So that one doesn't even, it's just not related. And then D, pancreatitis. Well, it can't be pancreatitis because pancreatitis is caused by triglycerides that are greater than 1,000 milligrams per deciliter, not the downstream of ketone products. All right, guys, this is the end. We have reached the end of lipids, of chemistry ASCP preps, studying with Thalia. If you were able to hang on that long, you truly are a soldier because that is a lot of material and it's a lot of stuff that you have to know, but I'm here to do it with you. So if you have any questions, anything specific that you didn't understand that you want me to clear up, please let me know. If you have any other types of questions in any area, also let me know. We'll eventually get there. If you found this helpful, please give your girl a like, and remember that this is for educational purposes only. It's just to give you some high yield notes for ASCP study prep. I hope that you guys all study hard and lock in, get your head right in the game. And if you found my channel helpful to you, go ahead and subscribe. That way you know the next time that I drop another piece of content on the ASCP study guide. Until then, y'all keep your head up and we'll talk soon. Take care. God bless.